We are back. All right, that pesky back pain, which can be utterly debilitating. How do you fix it? Surgery is just too scary. Well, I have someone on who will help, from Prescott radiologist and vascular interventionalist, but that's a hard word. Vascular and interventional specialist of Prescott. I got it. Okay, Dr. David Lloyd, and you're a neuroradiologist.
That's right.
Great to have you on with us. Yes, at least I can say neuroradiologist.
That's right.
Usually.
That's a mouthful. Yeah.
I don't know where this interventional thing is. That's really tough. And we'll just call it VISP. How's that?
That's great. Long words make us feel better.
Well, I tell you, when you say non-surgical remedy for back pain, that is like, what? That is an amazing thing. Now, what causes back pain, would you say?
Well, there are a lot of causes of back pain. In fact, unfortunately, 85% of back pain, we don't really figure out what the causes are, unfortunately.
Really?
So it's
not a visible thing, then?
Exactly. Or sometimes we're just left kind of shrugging our shoulders, shaking our heads, which can be very frustrating for patients and doctors alike.
Because it could be muscular or all kinds of things.
But muscular pain, back spasms, obviously degenerative changes like arthritis in the joints of the back, fractures are common in the elderly.
And now you can see those on MRIs or
Exactly.
whatever.
Those are, you know, we have a lot of tools at our disposal to help diagnose these conditions, which is, you know, why radiologists are, quite frankly, intimately involved in the diagnosis and treatment of back pain frequently.
Which is interesting, because I don't know if they have always been involved, but they are now, and why? What's the advantage of having a radiologist in on the consultation?
Well, imaging plays a huge role in medicine in general, of course. I mean, it's very rare that a patient goes to the hospital and does not receive an imaging study, whether it be an X-ray or a CAT scan or an MRI, and back pain is no exception. When a patient complains of back pain, it's very hard to know what's going on unless you do get some type of imaging. And the radiologist is going to be your doctor who interprets that image and gives your primary doctor kind of some guideline or a roadmap into what's going on.
I love it. Now, are people, you know, some people more susceptible to back pain, like age or ethnically? Or
it does depend on the cause of back pain. For example, fractures of the spine, particularly compression fractures of the spine, which are when the nice rectangular shape of the bone kind of collapses a little bit. White females, and here we have an image you can see as is an MRI. That white bone you see amidst all the dark bones, that white bone, you can see it's kind of collapsed a little bit. That's called a compression fracture, and that usually occurs in elderly women or men who have osteoporosis. White women who tend to be skinny and Caucasian.
We lift too many heavy things, I'm thinking now.
No, exactly. They tend to be the most at risk, but obviously those are risk factors we can't control. Things we can't control are smoking, of course. That's a terrible thing to do for your bones.
Okay, so this non-surgical options, what are these options to treat back pain then?
You know, unfortunately, surgery sometimes is the only option left for some patients. But for the vast majority of patients, there are things we can do to help them. In this particular case, this image here, this is an MRI of a lumbar level of the spine in the lower back. You're looking at an image where it's kind of like a loaf of bread that we kind of slice. And so you're looking at the slice. The image on the left, outlined in yellow, is how the spinal canal, where all your nerves go through, that's how it's supposed to look. It's kind of wide open, it's very bright, and the image on the right, it's very tight. That's what we call spinal canal stenosis. And so what we do is we can just kind of go in with this very, very thin needle.
AKA a hat pin.
Yes, exactly. It's very, very thin. It is long. It can sometimes maybe be intimidating to patients when they hear that we're going to stick a needle in their back. But this is a very thin needle we just insert, as you can see in this image here. Those are many different needles. There's 4 white lines. You see those are needles going into different locations in the back, some into the joints of the back. The one in the middle is going into what we call the epidural space. That's the space around that narrowed canal where all the nerves come out. And through the needle, we inject anti-inflammatory medicine, strong anti-inflammatory medicine.
So you can get right in there where it is.
Exactly. It's obviously not going to open up the canal. Sometimes surgery is needed to open up that canal. But in a lot of patients, we can at least relieve the pain, and so that they can postpone, if not just avoid surgery altogether.
And depending on their age or whatever.
Exactly. The image that we have here is an example of the treatment we do for those compression fractures you saw earlier on the MRI image. For example, what we do is this is an image of a bone in the back called the vertebral body. What we do is we insert this needle here into the bone. We just make a very, very tiny incision in the back. It doesn't need stitches afterwards, just a Band-Aid. Through that incision, we insert a needle into the bone, and you can see the needle goes into the bone itself, if you can see that.
Oh, yeah, beautiful.
And so once we have that needle into the bone, we inject through this needle that we can obviously open. We inject cement material. It comes out looking like Elmer's glue.
You're going to mortar up the spine,
Exactly,
aren't you?
exactly. And that's what you're seeing on that image there. That black stuff is the cement.
So it gives it support?
It stabilizes the fracture. And what's amazing about it is that 90% of patients receive pain relief from this procedure with these fractures, and the vast majority of them receive relief within the first few hours after the procedure.
That is phenomenal.
So one of the most satisfying parts of my job is being able to have these elderly women, for example, in tears, in wheelchairs, when they're normally not in wheelchairs, they're normally active, and they're suffering immensely from this pain. And after my procedure, they basically get up a few hours later and they're able to say, hey.
That's like a miracle. This is like a total healing. I mean, that is an amazing thing. Now, was this normally, it used to be a surgical thing where if it could be fixed, it had to be surgery?
Vertebroplasty has been around for probably the mid-90s is when it became came to be. Before that, patients just unfortunately kind of had to wait till their body healed on its own, which it will, but it can take a long time.
And meanwhile,
you're having severe pain.
Crack in your vertebrae,
Exactly.
and it's causing you a lot of agony.
Exactly.
Well, this is amazing. So this is kind of, I say, some of the technology's been going on, but it certainly is less expensive, less painful, and the recovery would be nothing.
Safer, of course. Exactly.
Right. So how do people find out if these kinds of things will work for them?
Well, we do have a vascular interventional specialist at Prescott. We do have a clinic, and we, of course, welcome any patient who has questions or concerns about their back and any pain that they're having to ask their doctor for a referral. We're happy to see them in clinic. We can discuss with them their options. Obviously, some patients are candidates for these procedures, some are not. The vast majority of patients who have compression fractures, if they see us early enough, they are candidates. Traumatic-induced fractures, you know, a 20-year-old person who fell out of a tree and fractured their back, we're not going to do this kind of procedure on them. This is primarily reserved for patients who have osteoporosis, and that's why they.
I see, and where surgery just isn't a good option.
Exactly.
Period. So, wow, Dr. David Lloyd, neuroradiologist with Prescott Radiologists and a vascular and interventional specialist of Prescott.
That's right.
You whipped that right off your tongue like nothing. Anyway, that's really, really good news for so many, many people. Dr. David Lloyd, thanks for joining us.
Thank you, Sandy. Thank you for having me.
Wow, I tell you, needles are still very much preferable to have to go under the knife, so that's really good news.